Hello and welcome everyone. Today we'll be discussing an important topic, that is metabolic alkalosis. A primary acid-base disorder characterized by increased bicarb and a pH of more than 7.45 is considered as metabolic alkalosis. It is very common in the ICU setting, and the diagnostic criteria focuses on finding the etiology and the dominant maintenance mechanism. It is when you know this, you can try to treat the condition. So the first thing that you must do is check the respiratory compensation. The metabolic alkalosis triggers a hypoventilatory compensation within minutes to hours, rising the PCO2. The compensation reduces the arterial pH but typically remains more than 7.45. The hyperventilatory response varies with the increase in the bicarb. The other important thing that we must know is the serum chloride levels. Usually the chloride levels will be reduced, and it is this chloride level reduction which is causing the metabolic alkalosis. And in metabolic alkalosis, the increased bicarb is usually associated with chloride decrease despite the sodium remaining same. You do find an increase in the anion gap because of the plasma protein's contribution in a reduced volume increases the negative charge. So the problem that we do face in our ICUs is the differentiation between a metabolic alkalosis and chronic respiratory acidosis. Now what happens is this chronic respiratory acidosis patient, that is COPD patients, they tend to have a compensated bicarb increase. Now what happens is once these patients tend to develop some kind of a new respiratory disorder, they will get tachypneic. Now with the new tachypnea, the PCO2 can go slightly below, which in turn can result in a increased pH with an increased bicarb, which was already increased. So you tend to get confused as to whether my patient has a metabolic disorder or a respiratory disorder, because as the compensation for this acute change may take time. And what happens is it is really very difficult. Usually from history you should be able to differentiate, but if you want to differentiate just by looking at the ABG, it is very difficult. But grossly, if you can think, then metabolic alkalosis will tend to have a little higher pH than the chronic respiratory acidosis, but this is very difficult. The best method would be to take a proper history. Venous blood can be used to approximate for it. But what we need to understand is, to understand metabolic alkalosis, we need to understand the physiology of the H plus and bicarb handling by the kidney. So the first place that we look for is the proximal convoluted tubules. So this is the tubule cell, this is the lumen, and this is the blood. The whole idea is to reclaim the bicarb which is coming over here. To do that, the cells, they using the carbonic anhydrase, produce the H2CO3 from the water and carbon dioxide, that is H plus comes over here and bicarb. The other important thing that happens is you have a very active sodium potassium ATPase pump, which is constantly pumping the sodium against its concentration gradient into the blood and absorbing the potassium, thereby causing a negative action potential inside the cell. This negative action potential makes the entry of the sodium into the cell possible. So sodium now enters into the cell in the concentration gradient as well as the electrical gradient. So the sodium that enters combines with the bicarb which has been generated over here and goes into the blood, thereby reclaiming the bicarb. Now the H plus that has been generated over here will be actively pumped out with this H plus ATPase, which will combine with these further load that is coming and get excreted down. So this is a very efficient method which is called the reclamation of bicarb, and it usually reclaims around 85 to 90% of the bicarb load. Usually we don't find any defects over here. Most of the pathology occur over here, which is the distal convoluted tubule. In the distal convoluted tubule, you have three main cells. The first is the principal cell, the second is the type A intercalated cell, and the third is the type B intercalated cell. The principal cell is essentially the cell that is looking after my electrolyte balance. So it will have a similar pump in the basolateral, that is the sodium potassium ATPase, which is constantly pumping the potassium in and sodium out, thereby maintaining a gradient which is both electrical and concentration based, which results in the inflow of the sodium. Now the sodium which is coming in will also need to be neutralized. The chloride comes through the paracellular areas into the blood. Potassium is getting pumped out by these two channels. So this principal cell is essentially the one which is taking part in sodium retention and potassium excretion. Apart from that, we have two important cells, that is the type A intercalated cells and the type B. The type A is associated with acid excretion, that is it will release the H plus. So here you can see the bicarb is generated, H plus is generated. H plus is actively pumped by two channels, the H plus ATPase, the H plus and potassium ATPase. So this results in the removal of the acid. Now this will be continuously neutralized by the bicarb, but once it gets exhausted, you have ammonia and phosphate which will be used to neutralize the H plus. And here you have the anion exchanger where the bicarb and the chloride are exchanged. So this is the basic acid secretor. Here you have the base secretor, that is the bicarb is secreted over here. You have the pendrin channel which exchanges the bicarb with the chloride, thereby removing the base. So first thing that we must understand is there are some methods by which alkalosis will be generated. So what are these methods? Either we have an infusion of strong cation like the sodium in combination with weak anions or weak bases, weak acids like bicarb, acetate, citrate, gluconate. So a weak base with strong, weak acid with strong base results in increased concentration of the strong cation, thereby resulting in alkalosis. There is increased bicarb generation through enhanced H plus secretion in the distal tubule. We saw the type A cell. If the A cell generates more bicarb and reabsorbs it while secreting more H plus, it will result in alkalosis. The other is generous delivery of sodium chloride to the distal tubule, where the active sodium, because of the concentration, will get absorbed and you will get more as alkalosis. Potassium depletion can result in acidosis because the potassium will be conserved in the type A cells. We had seen that potassium will come in, the H plus will go out, so that H plus going out will result in alkalosis. Similar things will occur inside the cell as well. Next is the active loss of chloride, which you can lose by GI tracts either through vomiting or diarrhea. So the alkalosis is usually presents itself in various clinical scenarios. One of the most common scenario is extracellular fluid depletion with low chloride. In this, you have mechanisms by which you are actively losing chloride, the last as we had seen. Here, the causes can be gastric loss because of vomiting, chloride rich diarrhea, post chronic hypercapnia, as we had described, a patient who had just developed alkalosis because he was tachypnic because of a acute exacerbation of a COPD. Cystic fibrosis with major sweating, because sweating there will be loss of chloride, and thiazide or loop diuretics, where we are using the diuretics to reduce the volume, and more villous adenomas. So these villous adenomas also result in chloride secreting tumors. Now, as you can see here, in these cases you have a chloride concentration is low, and the volume is also contracted. So in the loop diuretics, you will usually find a high chloride, but this is after the diuretic effect has dissipated. That means the patient is having a low extracellular fluid level. So the body is now trying to conserve the water, so it will retain the sodium, and this retention of sodium will result in alkalosis. But then since my volume is already contracted, I get a low extracellular fluid volume. So most of the reasons are because of chloride loss, except this thiazide diuretics. The next is the volume is expanded and the urine chloride is more, which means that the main reason over here is the sodium retention. So most of the reasons that you see over, that is primary hyperaldosteronism, is because of the aldosterone effect, which is acting on the principal cells, thereby making more sodium come in, and that more sodium that is coming in is causing a metabolic alkalosis. So this is seen in almost all of the cases, whether it is severe cussing, exogenous mineralocorticoid, reduced 1-beta steroid dehydrogenase chronic licorice, which is an inhibitor of this enzyme, congenital AME syndrome, renin secreting tumors, some from a congenital adrenal hyperplasia, 11 beta hydroxylase deficiency, 17 alpha hydroxylase deficiency, Liddle syndrome. All of these syndromes result in increased aldosterone effect, increased sodium retention, a volume expansion, low chloride, and alkalosis. Now these conditions are called chloride resistant metabolic alkalosis. The next is the ECA volume is contracted but I am losing chloride. This is typically in the diuretics, when the diuretic action is actively going on, and this can be replicated in two syndromes, that is the syndromes which act like diuretics, that is Bartter syndrome and Gitelman syndrome. Now you have metabolic alkalosis due to other causes, and these are severe potassium deficiency, which we have already discussed, and we can have increased milk alkali syndrome, that is increased calcium. The high cation can result in alkalosis. The bicarb load is markedly in reduced GFR, so the bicarb load is coming but the GFR is not adequate, so the retention is more, so the bicarb is not getting excreted. Refeeding after fasting will occur because there is a lot of electrolyte imbalance, and this electrolyte imbalance will result in alkalosis. So these were the mechanisms by which alkalosis developed. Now we will look at the mechanism how the alkalosis is getting maintained. The first is by increased reclamation of bicarb, which is still continuing in the proximal tubule despite the alkalosis. There is a persistent extracellular fluid contraction. There is a potassium depletion which is still going on. There is a continuous and intermittent generation of new bicarbs. You have a distal tubular connecting ducts which are still defective. You have GI losses of chloride. You have exogenous alkali ingestion, and you have reduced GFR filtration because the GFR is less. So this is a flowchart which helps us in summarizing and managing alkalosis. Once there is alkalosis, check the compensation, take a proper history, rule out GI losses, diuretic usage, and surgery. If you have find any specific cause, obviously you have to treat like that. If you don't find anything, then check the calcium levels. If they are high, treat it as a hypercalcemia, milk alkali, or hypercalcemia of the renal failure, or even malignancy. If you do not find a calcium increase, check the spot sodium. If the spot sodium is less, then it will be chloride responsive, and it will probably be because of the chloride depletion. And if my spot sodium is not less than 25, then I will look for the spot potassium. If it is less than 20, then probably it is again because of some kind of a GI loss. And if it is no, then we will look at the blood pressure. If my blood pressure is high, it is because of mineralocorticoid excess, that is increased aldosterone effect. And if it is low, it is because of the diuretic effect. If it is a diuretic effect, then there are two syndromes, that is Gitelman and Bartter, which we will differentiate by looking at the urinary calcium. Thank you for your patience.